Good morning. Thanks, John. So good to be back here at Mayo. I had 10 of really fantastic years of my career, and I would like to extend a special thank you to Nick LaRusso, one of my mentors, and for his kind invitation to be present for this design conference. I'm a physician. Not only that, I'm somebody who's in charge of the production of physicians. So I very much come from elements of the dark side from what I've heard over the last day or two of the conference. But what I'd really like to advocate here for is to challenge you to really overshoot the moon. And over the next few minutes, I hope to be able to explain to you what I mean by that. There's been quite a few references to Michigan. I'm reminded that one of our notable graduates, William Mayo, actually came back here to Rochester, Minnesota, joined his brother, Charles, to really found the Mayo Clinic. He's done pretty well. Going back to Michigan, where I spend my time right now, Southeast Michigan, I'm also reminded that the Detroit area was long the home of innovation. In this photo, you can see Henry Ford talking with his mentor, Thomas Edison. If you ever get a chance to get into the Detroit area, try and see the Henry Ford Museum. This is a real temple to innovation. It's a wonderful place to see what's happened over the last century. But if you spend some time in Detroit, you also see another dimension. Detroit has been one of the most gutted cities over the last 20 years. It's not uncommon to walk through these areas that are, to me, reminiscent of a developing world where I spend a lot of my time. Detroit is one of the cities, Michigan is one of the states that's got the highest exodus, the highest flight, the highest unemployment rate. You can still walk the streets and see these vestiges of greatness, what things were like when innovation ruled supreme, and the fruits of that innovation were really driving the economy. What happened? Well, really, this is what happened. The Toyota Corolla. That came in, that was birthed. Where was it birthed? It was birthed outside the United States. What was the driver? Well, it was coming into an area of the market where people were not spending much time, attention. Sure, not General Motors or Ford or Chrysler. It was a segment of the market that they were ignoring. And basically, like much innovation, this came in and completely transformed the auto industry, and it's taken forever for the American autos to kind of refine themselves. I believe that we're at that point with the American healthcare system, and I wonder what's going to be our Toyota Corolla. What's going to be that big disruptor? Again, this was not just a device. It was a device that had to be conceived, it had to be marketed, but it also had to infiltrate the current structure to be transformative. What will be our Toyota Corolla in healthcare? Well, I think there's already a number of Corollas that are being built offshore, getting ready to be launched here. Many of these have a technology component. Technology, I believe, is necessary but not sufficient, and we've heard that throughout this conference. What about the human element? What about human capital? Let me just cite one example here in this red circle, Aravind Eye Institute. You know, they've done 20 million eye surgeries, the largest eye surgery and eye care facility in the world. Right now, they've got cataract surgery down to $16. includes 2 days in the hospital and a month of medications. And when people come in and look at that model, the Forbes, you know, their outcomes are pretty similar to ours. What would Rochester look like? What would Ann Arbor look like if suddenly this Toyota Corolla pulls into town? What would happen to a Mayo Clinic, a University of Michigan? Is this going to be our Corolla? And we see a number of these things that are happening offshore right now that I believe are going to be very disruptive in a good way for our healthcare system. So what's my space? I'm somebody who does, my focus is on education, human capital development, and this slide articulates what I believe is my problem statement, where I spend my time. And basically, it's a slide that shows the percent of the global burden of disease, where is the unhealth out there, relative to the global workforce. How many people do we have to take care of that? And where I spend a lot of my time is in Africa, largely with the Bill and Melinda Gates Foundation, trying to work on this riddle. Africa has got only 3% of the world's healthcare workforce, but it's got 25% of the burden of disease. I think that's where we're going to find our Corollas. If you look down and to the right, you know, we've got a lot of the healthcare workforce. We don't have that much of the disease. Remember, half the world, 3 billion people, live on less than $2 a day. I think that's where we're going to find our Corolla. So let me show you this map here of the world if you just looked at it in terms of land mass. For somebody who spends a lot of time in global health, who believes that education is there to transform, there's something that I'm inherently nervous about. If you had to, you know, a lot of times I hear people talking about global health to say, we got to go help these people. If only they had what we had here. If we could just bring a little piece of Mayo, a little piece of the University of Michigan to the troubled world, wouldn't it be a better place? So I'm inherently nervous, though, by a couple of these facts. Where does the United States rank in terms of healthcare? What would the World Health Organization say about us? Where do we rank? Well, we're ranked 37th in the world in terms of the quality, the nature of our healthcare system. We're right behind Costa Rica. Yet we're the most expensive healthcare system. I think the rest of the world is pretty nervous about us taking our bloated Cadillacs into these parts of the world. Whereas I think, again, that's where we're going to find our Corollas. So let's get back to what I do, healthcare workforce. What would the world look like if you kind of reconstructed a map based on physician population? Well, it would look like something like this. Africa disappears. What's the country that's got the most concentrated number of physicians? We heard about it in the first speaker, Cuba. Cuba has a mass production of physicians, and if, for those of you who spend time in Africa, you go to a lot of these African countries, that's what Cuba does for its foreign diplomacy, exports doctors. So you see the Cuban doctor movement that's there. Now, I could show you similar maps for nurses, because really, I don't think it's about doctors. I think doctors are grossly overemphasized in the discussions around healthcare. We often talk about this healthcare pyramid in terms of the healthcare workers. And you see the medical doctors down there at the bottom, the narrow part. You know, they're relatively few in numbers compared to nurses, community health care workers. But unfortunately, they're the most powerful. They often have the control of the system. They control the purse. Unfortunately, a lot of our training systems with physicians have been oriented towards training virtuosos. I know how to be the first violin best, not necessarily the conductors who can play best in the orchestra. This is something that is dramatically changing in places like Africa because they don't have that physician workforce. So there's a lot of changes that are going on there. So I wish I could have shown you my slides before I got to a design conference, because I quickly said, oh boy, I better make things look like a steel case and some of these other things. So here's my meager attempt, all right, to try and fit in. But I deal with the human resources to transform health. And education is one leg of it, but you do have to have a real mind towards population health, something that a lot of the traditional power homes, the medical schools, haven't been oriented towards. Government, financing, business, management, all of these things are necessary. But still, when we're talking about our medical culture, a lot of it sits in the academic medical center. These things are these ivory towers, you know, where you've got these lofty people pondering. I heard, you know, some comments yesterday about thinking about the corporate world and corporations. Well, for those people who are active in healthcare, a lot of times the universities have some of that same demeanor. I'm reminded of that comment that that if you knew the world was going to end tomorrow, try and get yourself as quickly as possible to an academic medical center, because everyone knows that they're 20 years behind everyone else. So. But one of the things that's really the challenge at hand that institutions are starting to do is to come down from the ivory tower and get out and make it work in the community. How do they get outside that academic medical center? I think many of us, we know that when we leave our home, we take a trip, we take a journey, our assumptions get challenged. We see things, we see possibilities through a lens that wasn't always affordable when you're in your own backyard. So here's where I spend a lot of my time in Africa, trying to work on partnerships to try and make academic medical centers relevant to the community. I think that's one of our problems here in the United States. A lot of times the academic medical centers have not been relevant to their communities. So again, most of this work is with the Bill and Melinda Gates Foundation. And my focus, my design area is education and education systems. So I'm just going to start with examples. The dots on this page show where we have a number of partnerships and models that have been established. But let me just take one to show you an example of what we're talking about. So Ghana is in Western Africa. And the healthcare standards in Ghana are very similar to elsewhere in Africa. You know, life expectancy is around 50, not that much different than what it was at the turn of the last century here. Very few healthcare providers. The ones that are there are in the big cities on the coast. So a number of our models, what we've done is to actually partner with the medical school and partner with the government to try and figure out how can we push healthcare out from the universities, the big cities? How can we make it relevant to the people of Ghana? How can the health ministry see what they're getting so that they can actually leverage the finance ministry to actually invest in this? So it's teaching us to be a different kind of partner, a collaborator with academia, but also with the government sector. And it's curious. We seem to be able to take to this easier there than sometimes we can do that here. So what are some of the kinds of examples or the products, if you were taking a tour, what are some of the things that you might find? I'm going to show some examples from the area of maternal and child health. So maternal death rates are enormously problematic in the developing world. So I've been speaking about 10 minutes. Since I started talking, 10 women have died from childbirth. And there's two big problems with maternal death in Africa and the developing world. One is bad hypertension, blood pressure, something that's called eclampsia. But the other one is postpartum hemorrhage. After women deliver, they can't stop bleeding, and they die. Probably a third of women in Africa have had, only a third of women in Africa when they're delivering have any kind of help with them to be able to facilitate that. So again, huge, big problem statement, maternal death rates. So by us being present in Ghana, we said, how can we try and work on a solution to this? How can we try and play a role? Here's a model that we came up with, and it's a simulation tool. And basically what this is, you can see the model on the left. It's crafted to look like a pregnant abdomen. And the birth canal, where somebody can put their hand in and press it in just the right way. They have to press that to light up all the lights on the box. And they have to hold it there for a time period to be able to really tighten up that uterus so it stops bleeding. So this was conceived in the context of our partnership with being in Ghana trying to work the problems. We weren't sitting in Ann Arbor saying, hey, gosh, this is cool. Let's find a place to take this. Ghana. This was actually working with our partners and trying to figure out where can we be helpful. Pamela Andrada is the designer of this. She actually has a degree in design and actually works with nurses, public health, and engineering to develop a tool. Now, the picture on the right is, who are we teaching this to? The doctors? They can, the patients aren't getting to the doctors. They're not getting to the nurses. So who we are training this, using to train this, is the traditional birth attendants. These are the women that in some societies would be the grandmother, the other woman in the community who will help and come in. And basically, they're put through this simulator and to say, can you keep the 5 lights on? That's what you need to do for a minute to stop the bleeding. So we've moved this out, and then we've created these teams. By when things don't go well, how can you connect to a nurse to the healthcare system? And this is something that is not done, as a shunt pathway around the academic medical center. This is what we're in partnership with. So, so far we've had about 900 births from this team of traditional birth attendants. We've had about 50 cases of postpartum bleeding, and not a woman has died. And how do we know this? Well, we have got the cell phone technology that each of these traditional birth attendants are given so that we can collect the data, so that we can feed this to the health ministry, so they can argue for money from the finance ministry to strengthen the schools so that we can do this collaboratively. So you see a lot of stories like this from people in the developing world. The stories that we haven't crafted as well as we should is, what is that doing to us? How does the University of Michigan benefit from this? Well, let me tell you, in several different ways. First of all, we learn better through the work with this model of how to actually do uterine compression. We weren't training our people right to do that in University of Michigan. So because of what we've learned there, we have changed our training paradigms back home. Second of all, this simulation model. Have many of you been to a simulation center at an academic medical center? This is now a huge educational home. And these things are expensive as all get out. All kinds of lights and sirens. So this model cost us $100 to make. And bringing it to Ghana, we're now setting up a production facility for this to create a business there for them to create these low-cost simulators. It can be produced in Ghana for $20. So what else have we learned at University of Michigan? What about this low-cost simulation? Do we need really the expensive stuff? Can we show how some of these low-cost items will work and can transform us back home? And probably the third thing that has been most beneficial to us is the value of working in interdisciplinary teams. When we're at home, we all have our patterns, we all live in our silos. We don't fully appreciate what others can contribute to our thinking. And suddenly we're working with engineers and business, and all those people are on our campus. But we come together there, we suddenly develop habits, and we're bringing those habits back home. So a lot of people, again, say, oh, we have an obligation to the developing world. To me, I think we have an obligation to ourselves to be in this space. This is where we're going to find our corollas. So that's the projects I work with throughout lots of Africa. A lot of the work I started with Gates Foundation has been picked up by NIH. They've actually put $130 million into creating these partnerships. And these partnerships are going to be measured by how health is transformed in the community. Not if they could make the ivory tower a little bit bigger, a little shinier, if we can get a few more papers out of this. So it's really exciting work. All of those dots represent projects that would have different stories similar to the one I gave in Ghana. Let me just tell you a few examples again of things that we're learning there that we probably should do here. Tanzania, University of California, San Francisco is doing a tremendous amount of work there trying to actually transform their curriculum. How are they doing that? They're requiring their teachers in the medical school, in the nursing school, in the pharmacy school, to go out to where people are working in rural areas and spend time with them and find out what are they doing, what should they be doing, but they're not being taught back in the medical school. All right. And this is now caught on. It's taking place in Ethiopia. For most of you, you'd be going, gosh, that just sounds like a pretty routine needs assessment to me, Joe. But academia doesn't do that in this country. Another place is Uganda. Uganda has become a lab bench with a lot of the work that's been going on with Hopkins to try and strengthen these areas. New things that we're learning about HIV transmission, but then the most simple places where we should be putting our healthcare dollars. So again, huge problems with maternal and child health. And one of the things that they actually have gone to a model is instead of creating more doctors and more hospitals, they're paying the motorcycle drivers and they give them a little token of money if they can find pregnant women and bring them in for visits and for delivery. Dramatically has shifted the maternal death rate. So these partnerships are constructed as enabling partnerships that are designed to build and strengthen. This is probably my most important slide, that I'm trying to pull back to that initial question, where's our corolla coming from? What do I see happening globally that's going to transform us back here? Well, this is the traditional education model for many of us, but particularly for medical education, we have a curriculum, we have some educational objectives, and we have assessment. If you go through this and you jump through all the hoops, you're a member of the tribe. You know, you're a physician. People just assume if you've done this, you can do what needs to be done. And I think that's one of the things I observe in our society right now. People see doctor or physician or advanced healthcare work, they really don't know, gosh, what can you do? I really need to think more critically about this. We don't do that with our airline pilots when we get on a plane. We kind of assume they know what to do, but we're much more critical and reflective of, this is not just a doctor. What is she capable of doing? This is a very old model that has been totally disrupted by what I see going on globally. And this is going to transfect us back here in the United States. So what's the new model? This is something that's called competency-based education model. You start in the community with the population or the health society's needs. So you don't have this kind of list of things, make sure you know about all these diseases. It's like, wait a minute, what's society wrestling with right now? What are the diseases that we really need to emphasize? Knowing those diseases, how should we determine the competencies of what we want people to be able to do to really impact those diseases? And what's our assessment that's based on that? And once we have that, let's drive the curriculum. Let's make sure we have a curriculum that supports that. Can you see the difference between the top and the bottom? So we're in this transformative place in education design where we really have to go towards what's needed. Let's make sure people can do that they're competent, and let's build a curriculum around this. This is going to be enormously disruptive. And why is that? It's enormously disruptive because once you define competencies, you may be outside the tribe. So if you go to Malawi or Mozambique, they don't have doctors, they don't have many nurses. So what they've done is they've trained what is the equivalent of high school graduates to do 5 things for a woman in obstructive labor. One of those is a C-section. And they are actually getting extremely good rates in terms of really bringing that maternal mortality rate down. Can you imagine having somebody that is not a trained doctor, not even a nurse midwife, doing a C-section? It's a little bit like what we were talking about with Aravind in the eye story. These aren't all doctors, ophthalmologists. But once we say, are you competent to do this? Do you have the requisite competencies? Okay, we're going to let you do that. We're seeing some of that go on in our own country right now. I'm a gastroenterologist. And it took me 15 years of training after graduating from high school to be able to do colonoscopy. Pretty common technique, pretty expensive. Right now, there's a lot of nurses that are starting to get trained for this. Those nurses have 5 years of training. Do it cheaper. They started to do the analysis studies. How are the nurses doing? They're doing pretty good, except most of the studies show that the patients are preferring the nurses. Enormously disruptive. What are we going to do with all of our gastroenterologists at the University of Michigan or Mayo Clinic? Looks like the Corolla is honking out there. So we're going to see, I think, some changes there. So I'm going to wrap up here. I'd like you to think for a moment and imagine our world if we didn't have the Apollo project. We didn't go to the moon. There are some people who would say, why'd we go to the moon? We don't have anything going on up at the moon. We don't have any stores, we don't have any labs. Why did we spend all this money going to the, why didn't we spend the money on things here? It's hard to do that analysis if we took away going to the moon on what would have happened from all the spin-off technology, all of the things that we've learned from going to the moon, even though we're not on the moon. There are some people who seem to have trouble trying to think about why should we be in the global environment for those of us who are trying to think about innovation transformation. It's not about actually being in Ghana, You're not going there to save Ghana. I think we need to be in this global space to save ourselves. These are where our Corollas are going to come from. This is where our assumptions are going to get challenged. This is going to be one of the biggest drivers for innovation. And I would like to end by saying, get out of here. Leave home. Go spend some time, work the problems, be there for the germination, and then figure out how can we actually integrate this into these arenas. Thank you.
A couple of things, Joe, just before you go. So it's gone from doctors, gastroenterologists, to nurses. I guess colonoscopies at Best Buy. Is that next?
That's right.
That's where we're headed. You fly with that uterine simulator thing on planes to Gaza or to Ghana. Is that right?
We started, but now we're producing them in Ghana.
But you've flown with it. But you ever had to explain to the TSA what that thing is? No?
Hasn't come up.
All right. We made an executive decision on that slide that you did with the stool.
Yeah.
The kind of designy slide thing. Can we give Joe a... Yeah. I mean, I was going, wow, that's incredible. I mean, I know you're a gastroenterologist and you're totally out of your comfort zone. Even given the talk of colonoscopies, comfort zone is a very elastic concept.
That's where I
there.
live.
Yeah, right. But here he is, man, just out there, taking steps on the design moon, okay, with that slide. But then you went back to the boxes with the arrows, And okay, so he's got a ways to go. But we made an executive decision here at Transform. We're going to make you an honorary designer, Joe. And as an honorary designer, please stand, everyone. We're going to give you Bill Drentel's glasses, lime green glasses clips.
I'm touched.
You are an honorary designer. Thank you very much, Joe.
Thank you, John.
Take care.
Thank you.